Good afternoon, ladies and gentlemen. Our webinar is going to begin. I'm Steve Love here at the DFW Hospital Council. We want to thank you for being with us today. We're hosting another educational webinar in cooperation with OSPECS Consulting. They're an associate member of the DFW Hospital Council, and they've done previous work with our foundation. Today's topic is peer collaboration, the blueprint for accreditation success. This complimentary event is going to examine some of the changes that are driving surgical services and sterile processing departments, especially, as you know, that's quite important during this COVID-19 pandemic. And they're going to identify factors that impact and affect the sterile processing department operations and give details on how to achieve perpetual readiness. They're going to also discuss the peer methodology for OR and sterile processing success. We're going to have three speakers today, led by Mary Oliveira, who's the president and CEO of OSPECS, Marilyn Main, who is a clinical consultant and accreditation specialist, and Jonathan Wilder, a technical consultant. During her career, Mary Oliveira has strategically implemented Lean Six Sigma principles in surgical service areas. She's developed numerous educational and certification programs within the field. She was named one of 30 most influential people within the field of central service. Together, Marilyn, Jonathan Wilder have a combined 50 years of experience in surgical services. So as you can see, we've got an excellent panel of speakers, and we look forward to hearing their presentation. And with that, I'm going to turn it over to Mary Oliveira.
Thank you, Steve. We would like to thank the DFW Council and you for inviting us here today to participate in this program. We also would like to welcome everybody who is listening to us and hope everybody remains safe and healthy. These are very difficult times, so we want to make sure everybody is keeping themselves safe. So Steve presented the objectives of our program. Our goal today is to help you gain the knowledge you need to prepare yourself for a successful accreditation survey. To help you sustain readiness using our 4-step program that we name peer methodology. We can ask the question, why is it important to understand these concepts and remain in readiness status? Well, because in the last few years, the media has made the general public aware of how surgical instruments are reprocessed, and many articles have been written about incidents and potential death that have happened in hospitals and operating rooms. So almost on a weekly basis, we get an electronic newscast informing us of another incident related to improperly cleaned and disinfected surgical instrumentation. So these incidents, a lot of times, result in death or in an infection that impairs the patient's ability to perform in the future or resume their full activities. There have been many surgical services and SPDs that have been closed by the local health department, and many lawsuits have been brought up against them, damaging their reputation, and the healthcare facility is suffering from financial burden. This media exposure has also put pressure on accrediting agencies, and they're asking them basically to be more diligent and focus on the problem areas. So a couple of years ago, on a newsletter that the Joint Commission published, they stated that they found that immediate threat to life declarations directly related to improperly sterilized or high-level disinfected equipment increased significantly during the years of 2013 to 2016. They also said that 74% of the immediate threat to life declarations were related to improperly sterilized and high-level disinfected equipment. Now, these are very alarming statistics. And by the look of it, we can say, or we can conclude, that the efforts that we're placing in reprocessing surgical instrumentation results 20% of the time in defective processes. Now, does this mean that all of a sudden sterile processing began to make mistakes and we went bad? Well, I don't think so. And it doesn't necessarily mean that, but it shows that this very important task that we perform in sterile processing have been left without the support, the resources, and knowledge needed to make the department successful. So in addition to these factors, we also have major drivers in the industry that have been impacting the functions of the SPD and the operating room. So let's review some. When I started in sterile processing, all we had was soft tissue instrumentation, scissors, clamps, some retractors, nothing very complicated, nothing that had to be taken apart. And the most technological instrument that we had, it was power equipment, and it was connected to a tube into a tank. Not much to do, very simple, very, very easy to do. Today, we have the latest technology in surgical technology, and it requires a lot of specialty equipment, and those instruments require special cleaning and require special sterilization processes. Some of the latest robotic instrumentation require a very lengthy process to be cleaned and then goes to another process for sterilization. But the benefit that this robotic instrumentation do in surgery for those patients outweighs the long processes that we must accomplish in order to get them ready for the surgery. Then we have the mandates from federal and local authorities that we also must follow. And every state has different rules, although sometimes the federal rules override the locals. In one of the Health Alert Network newsletter that the CDC published, they indicated that healthcare facilities should allow adequate time for reprocessing those instruments to ensure that we adhere to all of the steps recommended by the device manufacturer. But guess what? At times, it seems like we're so far away from being able to accomplish that, and central steriles continue to function in a very rapid pace in trying to catch up with the operating room. Then we have the emerging infectious diseases. Through the years, healthcare organizations have been fighting infectious diseases. In fact, there was an initiative a couple of years ago by the CDC called the Antimicrobial Resistance Challenge. And in this challenge, the government and industry joined forces to fight against antimicrobial resistance microorganisms. And this is still going on. Every state, every private industry, they got together and they said, we're going to do this in an effort to fight antimicrobial microorganisms. But today, we have a bigger challenge. Today, we have COVID, which has come to change how we do business also in the hospitals. So these challenges pose a great financial burden on healthcare organizations, as reimbursement is eliminated for incidents of hospital-acquired infections. Then we have the accrediting agencies being laser focused in critical areas like SPD, endoscopy, and the OR. In fact, in my last survey, the first thing the surveyor asked me was, where is your endoscopy area and where is your sterile processing department? Because we are going there. So no longer these areas can remain anonymous to the surveyors like they did many, many years ago. Then we have the public, which is now very aware of what happens in the OR and in sterile processing because of the mishaps that have been publicized on television, on the newspaper, and on those electronic journals. In fact, I have received calls from educated customers or patients who call my department before they go through a surgical procedure to ask me, what are the measures I take in order to ensure that the instruments are sterile? And we're seeing that more and more. So this awareness also places the operating room under the microscope.
Yes, there are many factors that influence infection prevention practice in perioperative services. Some barriers that promote inconsistent practices are lack of knowledge. Does the staff know what the standards are? Are there consistent methods in carrying out the standards? Are leaders holding individuals accountable, or do they address the entire team repeatedly? Are there available resources? Have the correct labor, supplies, and capital been budgeted to meet the needs of the department? Is there uncontrolled staff call-out, untrained staff, or inventory management issues? Have provisions been made for cross-functional OR, SPD, and EVS teams to meet? Efficiency expectations also contribute to inconsistent practices. Have you assessed infection prevention practices during first case starts, during room turnovers, or even during emergencies? How do these impact your practices? Is the staff given feedback about the performance improvement outcomes? Do they know how they are performing as service lines? And do they know how they're performing as individuals? These are only a few factors influencing our ORs. Many OR directors are also responsible for sterile processing departments. There are more factors influencing our SPD operations. As Mary mentioned, healthcare organizations have been fighting the battle of antimicrobial resistant bacteria. Today, we are facing the greater fight with an emergent pandemic, COVID-19. There have been new emergency reprocessing guidelines for disposable N95 masks and PPE. This process has overwhelmed many SPDs throughout the nation. The rapid pace of research and development poses a threat to our knowledge of handling complex instruments. Many have small parts that need to be disassembled. Robotic instrumentation have long cleaning cycles and complicated instructions for use that are hard to duplicate in a real SPD environment. At times, these IFUs are not even available to the technicians. Rapid turnaround also impacts the technicians' focus on the trays. Is the block scheduling impacting overutilization of ortho or other service line trays? Limited resources are not only applicable to labor and supplies, but also the capital equipment and instrument tray purchases. Are trays waiting for steroid? Are scopes waiting for high-level disinfection reprocessing. I can tell you, a high volume OR is very desirable. However, we must also have adequate resources to support the operations, such as enough instrument trays and reprocessing equipment. Following recommended guidelines is the gold standard, but we cannot cherry pick the ones we will follow and the ones we will not. If the theme is not good, there might be major consequences. How can a facility remain in readiness status? Next. Next slide.
So how can a facility remain in readiness status with all of these factors and that are constantly influencing the outcome of the process? Is there a simple way that we can use to remain in perpetual readiness? Well, yes, our simple four-step program breaks down the readiness into sections. Each section outlines the step that we can take in order to achieve readiness. So we divide them into prepare, where we're going to go through a preparation, we're going to examine, we're going to educate, and we are going to rebuild. So let's take a look at that process. So the first step of the program is to prepare. So how do we prepare? What are the steps to prepare the department for readiness? An accrediting agency is going to be looking for adherence to standards and best practice. So we cannot prepare policies and procedures or conduct training or do performance audits if we don't know what the standards are and become knowledgeable and familiar with the requirements. So do your department or does your department have a library of resources that include the government regulation standards from local FDA, CDC? Do you know or do you have the local DOH requirements for sterile processing? Every state has different regulatory statements that apply for sterile processing. In New York, for instance, under the DOH regulations, it says that we must follow Joint Commission standards and AAMI standards. So whereas in many states, AAMI standards might be a recommendation, in New York, we have to take that a standard and apply it to our processes and not cherry pick the things that we are going to be in compliance. We should also be familiar with other standards. Do you have copies of the AAMI standards? In our department, we should have the AAMI ST79. This is the standard that speaks about steam. It gives us the outline and regulations or things that we should be following in our department for steam sterilization. ST91, if we're doing endoscopy, ST91 speaks about flexible endoscopes and what is necessary in order to process the flexible endoscopes. ST90 is the quality standard. If we are going to be implementing a quality management program, here are the steps on what we need to do. ST58 is the one that speaks about chemical and high-level disinfection. And those of you who still have ethylene oxide sterilization processes in your department, you should have the ST41, which has all of the statements for ethylene oxide sterilization. We should also have the ARN guidelines and SG&A. ARN recommendations for the operating room, recommendations for sterile processing, recommendations for endoscopy. SG&A, which is the professional society that also makes recommendations for endoscopy areas. But don't just tell your surveyor that you follow ARN standards or you follow SG&A standards, because the surveyor is going to be observing. They're going to ask you for your policies. In your policies, you need to have those citations. And the policy, if you have steps 1 through 6, when they observe the staff must be doing steps 1 through 6, not 1 to 3. And the accrediting agencies also have standards that we should be looking into, we should be following it, because they're going to be grading us on those standards. Those standards are based on CMS conditions of participation. So they have audit sheets. They're going to come in with those audit sheets, and they're going to observe our process and grade us about it. So a survey is a test. And when we're taking a test, we must prepare for it, we must study, and then we must pass it. So if we don't know the standards, if we don't have those standards in our department and we don't prepare well, we're going to flunk the test. So we must examine our department status, and from examining that, that status, we're going to know what we need to do. So we need to examine the condition, the state in which the department is. We are an integral part of the hospital. We are the army, which is in the hospital trying to reduce the risk of infection. So we must conduct risk assessments on a regular basis to ensure that our processes are sound and we don't pose a risk to our patients. So our position is that we need to create, in collaboration with your peers in the operating room, infection control, risk management, sterile processing, and anybody else in your organization that you think would be good to be in this performance improvement group, and prepare or develop checklists that are the focus on the auditing critical tasks that are going to help us highlight what our deficiencies are. So the Joint Commission does have a very good packet that is called the High-Level Disinfection and Sterilization Booster Pack. This document contains or outlines all of the standards that they're going to be grading us and what they're going to be looking for when they come into the sterile processing department and endoscopy area. This is a great document that is free. You can go into Google, you can download it and utilize this document as the base to create those audit lists for your department. Other organizations like CMS, they also have some worksheets that you can download and create them, or take some of those items to create a risk assessment in your organization. So our policies and procedures must also reflect the recommended standards and practices that we are doing. So staff must be performing, the tasks that they're performing have to be based on the steps that you listed on that policy and procedure. A lot of times I go into a facility, I read the policy first, and when I go into the department, whether it is decontamination or in the operating room or in prep and pack, and I observe the staff doing the steps, and they're not doing anything like what they have in the policy. So that is it raises a red flag, because the surveyors will be doing that. So we must also ensure that we develop key performance indicators to evaluate the consistency and effectiveness of the process that we have. So if we're not measuring what we're doing, we're not going to know whether or not we're doing well. or we need improvement? Is your facility conducting all of the efficacy and efficiency tests that we must do in order to ensure that the outcome of the process is successful? Have you performed the tests to ensure that your steam, water quality, temperature, air pressure are within the guidelines? This is the question.
So good afternoon, everybody. This is an example of things that should have been fixed years ago. Mary and I did an audit, and there was this is what in one location and in the hospital system is what the sterilizers look like. Situations like this cost money, and there are many costs. One is cooling the air around the sterilizer. Second one is wasted steam, and it costs money to make steam. Most important is this can cause wet steam, which leads to wet packs, which means you get to do it again. So that's no fun. Sterilizers, washers, all the technology you have to help you clean and sterilize the instruments, they have to be functional, capable, and proven to be so. On the next slide, please. One more.
Oh, I'm going in the wrong direction. There we go.
So on the next slide, thank you. On this, we're talking about situations where there are a lot of moving parts. There are people, there are machines, there are techniques. Mary just talked about making sure the techniques are being done correctly. Amy, I'm not going to read the slide to you, but Amy gives you good guidance in the standards that are mentioned here, and they work in two directions. ST90 helps you set a quality culture and a quality situation where you can measure what you're doing, and ST79 gives you the detail of how to build and test in the SPD. The point is that if you have a quality management system, you stack the deck in your favor. And if you do the quality control as described in ST79, you'll know that you're actually doing it. Now, when you have employees, you want the people who come to work and not just to show up and not just to sit around drinking coffee all day, no matter how much fun that might be. But you can look at your equipment the same way. If you've got 5 sterilizers, 2 of which aren't working and 2 of which are unreliably processing, and 1 is working well all the time, you have a real choke point for throughput through the sterile processing department. Next slide, please. So you got to feed them right. That means you have to feed washers need to have water. They should have what's called critical water, which is either RO or DI water, preferably. For your final rinse, you need compressed air. You need good quality steam. I'm going to talk more about that in a minute. And you need good quality electricity. Sometimes the electrical systems are noisy. Sometimes the voltage droops and things stop working. There are a number of things that have to be looked at when you're trying to make sure that things are going to be in a situation where they can perform the way they're supposed to. Water quality is described in AMI ST79 and then in more detail in the AMI TIR34 water for reprocessing medical devices. That document actually is, even as we speak, we're having the first meeting to turn that into a standard. So there will be more clarity in how the water you use should be prepared and what it should have in it and what it shouldn't. Steam quality and steam purity, as well as air purity for instrument applications, instrument air is defined in ST79. What is this stuff? Steam quality, you're looking at how much water is in the steam, condensate, that's your steam dryness. Water vapor is what you want to have. Water is not going to do that, going to do sterilization very well for you. The amount of air or other gas in the steam, again, a terrible sterilant, air or anything other than steam being in the steam. And superheat, well, that's the one that comes up and bites you, because that's the one that actually will either burn through filters or melt plastics. It's very rare, but when it happens, boy, is it spectacular. And the purity is the chemical makeup of the steam, and there are allowable contaminant levels that you really shouldn't go past. Steris Laboratories does a good job on that. I fill in certain blanks when I do my testing, but there is a lot to be looked at just to make sure that things can happen in a reliable manner. On the next slide, please. So if you've got bad water quality or bad steam purity, you're going to stain the instruments, you're going to corrode the instruments, you're going to decrease their life. They're going to have to go out for repair more often. Cost of ownership goes up. Availability of instruments for the things they're there for goes down. Bad steam quality, wet loads. Guess what? You liked it the first time, you're going to get to really like it the second time that you process it. Failed sterilization, less than sterility assurance level. I just had a case a couple weeks ago where I was called in. The steam sterilizers were failing Bowie-Dick tests and failing biological tests. And everything looked fine until I hooked it up to look for non-condensable gases. I've never seen so much air and steam in my life, and I've seen a lot of bad situations because I don't get called for the good ones. They had a failure in the pneumatic pressure regulator, and they were pumping air into the steam. Air is a terrible sterilant. And then finally, as I mentioned, superheat will give you scorched or melted plastics. You can burn through, you literally burn through a container filter. Next slide, please. So what do? Well, you analyze the water. That means water out of the taps that are connected to the same lines that feed the washer disinfectors or are being used for manual cleaning. And you collect condensate. That's where you get facilities involved because usually they have the tools to do that from the steam at the sterilizer. I don't care what happens in the boiler plant. The sterilizer isn't in the boiler plant. The sterilizer is where you're using it. So you need to safely collect steam condensate for analysis. Analysis can be done with test strips that you can get from industrial supply houses, or you can send it out to a laboratory. Steam quality, that's not so easy. Steam dryness level, non-condensable gas content, and superheat are not easy to measure for unless you have the right tools. That's where I come in from time to time when people really need me to help them. And there are other people out there who do this too, but I'm not going to mention their names. Haha. This should all be done to create a baseline situation where you know what the machines can do, what the machines are set up to do, and what capabilities you've provided the machines by feeding them in the right way with good water or good steam or both. And this is in the installation qualification, which in my way of thinking of it, installation qualification is you order something, it arrives, it's what you ordered, you plug it in, you hook it up to the utilities, and it doesn't blow up. Operational qualification is it passed installation qualification. You try to run a cycle, lo and behold, it actually runs. So that's good, but you have to prove that. You should have a baseline test at your facility because your facility is not the factory, it's not the hospital down the street, it's not the hospital here in Philadelphia. It's your facility, and everything's a little bit unique. I know you can't say a little bit unique, but it is. So people tend to do this when there's a problem, but you can do better than that if you plan ahead. And if you plan ahead by getting this testing done up front, you will have a lot less to worry about in machine performance because you know what they can do and you will have proved it. Next slide.
So now that we have examined the process, the next step in PURE methodology stands for education. Education is key for continual readiness. As a matter of fact, it's the foundation. You must know all standards. They can be interpreted by your professional organizations and industry experts, as Mary mentioned. One effective way to develop process methodology is to create an SPD and OR small group. This is a great way to collaborate and establish your processes. That group can also assist in developing audit tools, reviewing policies and procedures, and helping contribute to the education plans. Many of these tools and templates can be found online through your organization. Education of the team is accomplished by utilizing the correct method for your audience. As we know, not every adult learner learns the concepts the same way. Many learn by observing, these are visual learners. Others learn by listening, are auditory learners. And others have to perform the task by doing it. And then again, many may need a combination of the three in order to understand every step of the process. It's best to develop mastery of concepts by utilizing firsthand experience and practice. One way to engage your technicians in the learning process is to make learning positive and a fun experience. This encourages participation, and it's important to choose and focus topics, of course, directly related to their task. I don't know if any of you have ever used peer audits, but it is a great way to promote open communication. It's okay if they give each other the answers and direction on the spot. They support each other. They learn to communicate this way. When team members audit each other, they can point out the varied process methods that they can see from one team member to the next that needs standardizing. Of course, our peer audits are always followed up by leader audits, and leaders audit leads to coaching for individual accountability and success. It's imperative that we empower our staff with knowledge. Knowing that education is the foundation to our success, what is the next step in addressing our deficiencies? Next.
So this appears to be me. If you assess your people and their skills, if you assess your equipment and its capabilities, you'll be able to find the sore thumbs that need to be dealt with first to get you 80% of the way to goodness. The action plan you draft and create from that examination should be prioritized, and then you get a collaborative team together. And this could be anyone in the hospital that can, or in the healthcare facility that can be useful to you. This could be, again, facilities engineering, biomedical, SPD, peri-op. It depends on the problem who you pull in, but you have to be able to pull them in. If you are going to do this, you may wind up doing things 180 degrees different from where you started. You have to be willing to have your eyes opened by the problems that are there. The most dangerous words ever spoken anywhere, or we've always done it this way. Well, we don't do it that way anymore in some cases, or maybe we do. But the times when we don't, those are the situations where you want to implement new thinking, new practices, and make sure that things can get onto a good state of quality maintenance. You have to do quality audits, you have to do accurate record keeping process, and make sure your processes are consistent. That means test the people, test the washers, test the sterilizers, test the water, test the steam. Because if you don't know what something is doing, it's out of control by definition. And if it's out of control, you can't count on it to be there when you need it. Next slide.
So whoops, went too far. So we have discussed drivers and factors that influence the performance of the sterile processing and the operating room. We've also discussed a simple process in which we can break down sections of the preparation process, and we can utilize different teams to work on those areas. Getting ready is a challenge. It's not just implementing processes for the accreditation readiness. It's going to take a 180-degree turn into a new path of compliance and best practice. But the benefits that we are going to get from having a different approach are going to be exceptional. Your processes will be standardized. You can reduce waste and reduce trays that need to be reworked. it would build your team, it will increase customer satisfaction, and most importantly, it's going to increase patient safety outcomes. So what would happen if we do not make a 180-degree turn into a different path? Well, the Joint Commission told us that the consequences are significant when they publish this set of consequences for process failures. We could place patients at risk of contamination, and we've seen that in the many articles that we've read where people have been contaminated with dirty instrumentation, and at times those patients have died. We can cause potential outbreaks. We are living today an outbreak. We see what an outbreak can do to our population and our patients. We can get potential loss of the accreditation, whether it is from Joint Commission or DNVGL, and the hospitals that have been closed down as a result of improperly clean instrumentation, they have lost a lot of revenues because they could not open their operating room until those issues were resolved. We can potentially lose the CMS designation, which is what helps hospitals get insurance and charge patients with Medicaid, Medicare. So recovery of these revenue losses are very, very critical. Bad publicity, loss of business, damaged reputation. Once your name is on a newspaper or in an email blast, it's very, very difficult to recover from that. And add to that the litigation that is going to come after patients hear that the hospital where they had the surgery had a problem with dirty instrumentation, and you might be contaminated with HIV or something else that can be detrimental to their health or their life. So in summary, perpetual readiness and preparation requires dedication and commitment. So let's make a commitment today to drive change in your organization and make that 180-degree turn into that new path of compliance and best practice, and therefore ensure that our patients are safe. Let's make sure that those instruments and that surgical procedure that we are performing today is to the expectation of that patient that came to have that procedure done. That even though the only person that they see in the front run is the physician, they don't know who else is involved in performing this task, so they can come out of that surgery without any adverse reactions. Break down the readiness process into manageable sections, such as preparation, examination, education, and the rebuilding of your department. So when the surveyors come, you can show them how beautiful your department is. Create those teams, those cross-functional teams that are going to look at things from a different perspective. Sometimes we don't include the sterile processing technicians in those meetings, but guess what? They're doing that job on a daily basis, and they know how to do that process best. So sometimes we need to take a step back and listen to some of the suggestions that they give us, because some of them do have extraordinary suggestions. So once we do this, it can be very rewarding, because you're going to have a sense of accomplishment, and you will be able to finish all of these immense tasks quicker, because you have people helping you complete this preparation process. Don't be afraid to reach out also and solicit help. There are many people who are willing to give you guidance. This is why we network. This is why we go to seminars. This is why we meet other professionals. This is why we go to those annual meetings where there are many people that we can get phone numbers. So when we have questions, we can get on the phone and we can call and ask. So this network of professionals are going to help you come to the next level. So the message is, remember guys, there is no time to waste, and we lead and we have to lead the way to excellence. Thank you very much. If you guys have any questions.
Well, thank you, Mary, and thank you, Marilyn and Jonathan. That was very good presentation, and we appreciate it. And we do have a couple of questions. Here's the first question, Mary. How can we begin to establish a functional work group within the OR and SPD?
I'll be happy to answer that. This is Marilyn. First and foremost, the OR and the SPD leaders must understand the standards and the needs of each department. These leaders must be committed to collaborate versus being territorial about their own departments. You can set the team up with leaders, with lead OR techs and lead SPD techs prior to bringing in the staff. It's best to have a small group start. And you ensure representation from days, from evenings, from nights, and list the concerns and the standards that need to be addressed. Develop action plans, assignments, indicate the follow-up, and keep the entire OR and SPD teams abreast of the many outcomes. This will result in the development many times of OR liaisons for day-to-day operations. That's just one of the first ways to get it set up.
So I would also add, I would also add to that we have to, the first thing that we have to do is begin to build the teams. In a lot of locations, sterile processing and the operating room are two different locations, and the sterile processing staff never comes into sterile processing. So the first step is to get those teams, both teams, to get together and network and understand that one needs the other. And once we look at each other as essential to each other's task, we would begin to create more collaboration. But the first step is to build the team.
A little bit more on that. One of the things that you always hear sterile processing folks talking about is that the OR wants everything now. Well, they need everything now. That's a given. But part of that is because the OR doesn't necessarily understand what SPD does and how long some of these processes take. They're getting faster and faster, but I think it's very important for people to do a tour to see what happens in SPD, and similarly for SPD folks to go up to the OR, and because it usually is upstairs, and see how the instruments are used. This could lead to fainting during procedures, but normally not.
Good answer. Here's another question we just received. Is immediate use sterilization in the OR acceptable, and will accrediting agencies cite us for doing it?
So immediate use sterilization is the new term for what we used to call flash sterilization. And the term was changed, and it was not because flash sterilization was bad. The problem with the immediate use sterilization is that the preparation process, or this decontamination and preparation process, was being bypassed and things were being sterilized with bioburden or some other flaw that it would end up in the surgical procedure. So we do try to reduce immediate use sterilization, because what happens is we tend to utilize this process as an alternative to buying instrumentation. So by rapid turning these instruments, we tend to not have the adequate number of instrumentation. For instance, in those hospitals that have a lot of eye procedures, they have a couple of trays and all they do is immediate use sterilization. So will the surveyor rate you negatively on this? We must have adequate records that include the name of the patient that we use the instrumentation on, the time, the procedure, what was the detailed description of that item, and the ticket from that sterilization load must be verified when the cycle is completed. All of this record should be in one page. So when you're looking at it, you have all of your documentation together. The other thing that is very important is that we are running those efficacy tests, the biological cultures, on the sterilizers at minimal on a weekly basis, desirable on a daily basis. But all of your records must be in place and show that you're not using immediate use sterilization as an alternative from buying additional instrumentation.
If you're doing implants, you have to put a biological indicator in every
Yes.
load that you have implants,
Yes.
so that is expected by Joint Commission and DNVGL and CMS.
Yes,
And
there's specific guidelines for sterilizing implants, and in many occasions, only when it's an emergent situation, you can do immediate use sterilization, and always follow the manufacturer's recommendations, the IFUs.
Okay. We've got a couple other questions. One of them is, what are the acceptable levels of steam quality parameters per AAMI ST 79?
I will be happy. It's one of my favorite questions. So steam dryness, which is a measure of the water vapor content in the steam, should be at least 0.97. What does 0.97 mean? It means that it's 97% water vapor at least, and 3% water, but where? Well, ST79 isn't so clear on that. The answer to that question is that it's on the steam coming to the sterilizer. So that is that's where you should measure it. As far as the sterilizer manufacturer is concerned, the sterilizer ends at the inlet part of the steam strainer that you hook up to your facility's plumbing, unless you have an onboard boiler if you have a smaller machine. The European answer to this question is 0.95 or 95%, but they measure it on the steam going into the chamber of the sterilizer, so that's a little different. If you have 0.97 going into the sterilizer, you very, very likely will have 0.95 going to the chamber where it does all the work. Now the next bit is non-condensable gases, which is 3.5% by volume. So you want to have, it's similar, you want about more or less 3%, no more of what shouldn't be there. So you're looking at separating that. That's a measurement by volume. The measurement for steam dryness is done by actually calorimetry. In other words, you take some water, measure the weight, measure the temperature, put it in a thermos or a calorimeter, take your choice what you want to call it, it's still a thermos. Heat it up with steam from the machine and weigh the weigh it at the end of the measurement and take the temperature, and incant over the steam tables, which are how you get the relationship between pressure, temperature, heat, and so on in the steam, and you get an answer. And the last bit, superheat, the answer is 25 degrees C above ambient boiling point. So typically everybody says it's 100 degrees C, 212F. ST79 has a glaring error because somebody forgot that it's a differential temperature, and it's 45 degrees F, not 77 degrees F. Because you're going from one temperature to another, you're not going from starting at 0. So you're allowed up to 25 degrees C or 45 degrees F over the ambient boiling point of water. I have rarely seen more than 105 C, 5 degrees C over, or which would be 9 degrees F.
Okay. And our final question that's been typed in here is, what is the name of the type of water that should be used for the final rinse in cleaning and in decontamination?
That is critical water. Critical water is defined in AMETIR 34. And they call it that because it's critical for your processing. There are actual numbers attached to what that means, and you can find them in Table 1 of AMETIR 34. If you send an email to Mary at the OSPECS info at OSPECSconsulting.com, we can give you that information.
Okay.
There are a lot of numbers in that table, and I'm not going to just reel them off, mostly because I don't have the table in front of me.
I understand. I understand.
Yeah,
well, that's the end of the questions. But Mary, Marilyn, and Jonathan, we want to thank you. What a great presentation, great follow-up questions. And Mary, I'll turn it back over to you if you have any final words before we close.
Well, we want to thank everybody for attending today. And if they want to get copies of the presentation, they should let you know. And we gladly will give them the deck. So thank you so much for coming today, and have a wonderful day.
Thank y'all. I hope everyone has a safe afternoon, and we really appreciate you participating.